So it's great to see you all here virtually and even on the bottom of my screen and talking about calcified solutions for endovascular therapy. Here are my disclosures. Well, we know severe calcium presents unique challenges. The devices either don't deliver, expand, or succeed as much, and there are more complications as you see here, and it can be harder to get the drug delivered to the vessel wall. So we have special considerations. Should we use embolic protection? Should we use calcium-specific strategies? Which stent to use and when? And what bailout equipment do we need? Well, I think unique challenges deserve unique approaches. We have a much lower threshold for using embolic protection or calcium-specific strategies. It's very important, I think, to aggressively pre-treat all lesions and then confirm the success of your pre-treatment before implanting a stent or using a DCB. And as is mentioned, interwoven stents are almost exclusive for me when stenting calcium. Here are strategies that I found to be effective for heavy calcium: CSI orbital atherectomy with embolic protection, or aggressive pre-treatment and then Sapera implantation, possibly with EPD, or the Shockwave lithotripsy angioplasty. These pre-treatments then coupled with restenotic therapies, DCB or Sapera. Other strategies can be used, and we'll look briefly also at the pave and crack technique, which can be very helpful. When we see a lesion that has microchannels like this, we like to wire those with 014 wires and traverse the microchannels, and then couple that with an 014 protection system, which is friendly with our atherectomy systems. All right, let's look at some cases. Here's a heavy calcified lesion. We did this as a live case. It was a trifurcation lesion and a dominant posterior tibial circulation. So the dominant posterior tibial and CLI, we protected that with an 014 wire system. Here's the CSI protected, done slowly. You can see the luminal gain and then higher rotational speeds, followed by a nice lumen and then focal force and DCB. Nice result in the lesion without dissection and no distal embolization. I think this highlights a lot of examples here. Here you can see a calcified short occlusion, then reconstituting a severely diseased popliteal. Here's wiring it with a glide wire, and then the microchannels, we're going to take that on with an 014 wire system, couple it with embolic protection, and here's slow CSI with embolic protection in this heavy calcium. This allows good balloon and DCB expansion, but notice the no flow despite this therapy. So what do we got? Well, we have a full basket from all that debris. So we wire into the basket, perform aspiration thrombectomy, get the basket out, leaving the other wire behind. And this is what we got from the aspirate and what we get in the basket and why we use these baskets, and glad we used it. So taking a basket out gets brisk flow and no distal embolization. What about stents? We've heard about this. Yes, if you pre-treat and use the right stent. For me, and as Peter said, it's the Sapera stent. It's got 5 times the radial strength, and yet it's conformable, flexible, and fracture-proof. You must adequately pre-treat it. I think it's a beautiful case to highlight this. Look at the calcified occlusion, long calcific disease, popliteal disease. Here's aggressive pre-treatment with embolic protection. The balloon's expanded nicely. Notice how well the Sapera stands up immediately upon deployment. Look at the Sapera without post-dilatation in that heavy calcium, fully expanded throughout its entire length, allowing a beautiful angiographic result in that heavy calcium. And more importantly, look how well it stands up to the calcium, and as importantly, how well it bends with the patient when the patient bends on a bent knee angiogram. Also, I agree with Peter in Shockwave being a very successful strategy for severe calcium. It has both low dissection and distal embolization rates and gives you a beautiful, nice lumen. When you're doing this early, I would encourage you to IVUS pre and post to see what you get. And again, you'll see this nice large luminal diameter, which is really good for larger vessels. Important with Shockwave to size it correctly, 1.1 to 1 of the vessel wall, so you're using a larger balloon. We inflate the balloon to 1 atmosphere and then activate the Shockwave energy. Usually you can inflate the balloon, but we try to keep it 4 atmospheres or less. You can go up and down with your energy level with the emitters and use the 300 cycles fully as needed. Look at the dense calcium here. You can see common femoral artery, heavily calcified lesions. In the past, we would have thought twice about doing this endovascular. Here we're going up and around. Here's that heavy calcium in the common femoral artery. Here's a Shockwave 7x60 lithotripsy balloon. Look at the results without dissection and a nice lumen. Here's an 8mm DCB. Nice result in the common femoral artery, no dissection, and without a filter, no distal embolization. Similar on the other patient on the right, same idea. You wouldn't have done this. This went into the SFA ostium as well. IVUS 360. Here's a Shockwave 7x60, adjusting the height into the SFA. Nice result, beautiful IVUS. Add the DCB into the SFA. Nice result. Notice in the basket, we used the basket early. There's nothing there in the basket, so we stopped using them. It's good for large vessels, like this, good for access type vessels. Here's a common iliac, Shockwave with a 760, nice lumen, no dissection, VBX carefully placed, and nice final result. This is one we did for TCT Live last year. Look at the 360 degree in the aorta. This would have scared all of us before. We've done now 12 cases like this. This is another one. Notice the hypertrophied collaterals here. This is heavy calcium, more than 80mm gradient. Shockwave from the left, shockwave from the right. And then IVUS kissing shockwave where you offset the emitters. Nice result. And now we can put a VBX in, do kissing non-compliant, angioplasty, add some VBXs, safe result done percutaneously. Last case, this kind of brings everything together. You can see this heavy calcium. We got subintimal, so we had a balloon just to get our reentry device. Notice that after aggressive ballooning, it got look really ugly and we needed more pre-dilatation. In this situation, it's not safe to go more aggressive. So this is a beautiful pave and crack. Here's a 7x250 Viabon stent graft, allowing you to be very aggressive inside the stent graft and then implant a large Sapera inside of that. And nice final safe angiographic result. So in conclusion, I think severe calcium gives us unique challenges, but these can be overcome with individualized calcium-specific approaches, which will use atherectomy protected lithotripsy angioplasty to pre-treat or aggressive angioplasty and interwoven stents when needed. And me and the kids and Steeler fans would like to thank you for your attention.